Yeah.
The support team helped
slides,
presenting slides. We also use this in lab coating Yukon. In fact, I was one of the first few people in the South India. It was very interesting concept those days, and we used lots and lots of those stands, and we had excellent results those days. And we had a lot of patients who had underwent follow-up angiogram of all those patients. And we hardly saw any restenosis in those patients. The only worry those days was like we're coating the stent in the lab, and when it goes into the machine, we were worried that some infection might come, and then that was taking an extra time in the lab, that coating process. So then what they used to do, they used to coat and then keep in. Then we were not comfortable. So they said, we'll coat and get it for you. I said, that's not possible. But then it was it lasted for a couple of years, and we never had a problem in any of the stents. In fact, we're all worried about the infection because it was just that the stent goes out and then the stents go implant there. But they were very perfect in all the concerns of the cath lab team. The technician used to say, sir, what is this? You're exposing the stent and you're covering in the lab. Where is the sterility? But we never had any problem. We used more than 100 stents at those days, and we had excellent results. So that's amazing. That was an amazing product. Yeah. Go ahead, sir.
Okay, thank you for this opportunity. So I will be discussing about hemodynamics in complex PCI. So it's a very dry topic. So I will be discussing about a pressure volume loop associated with all kind of available hemodynamic devices. So it's at least I have not read about this topic after my first year of MBBS. So just to revise it, y-axis is your pressure, x-axis is your volume. It starts from diastole. Starts from this phase point, end systolic volume. Diastole, the blood is entering into LV. Mitral valve closes here. Isovolumic contraction phase, blood is getting ejected into aortic valve. Aortic valve closes here. Isovolumic relaxation. So this is the conceptual pressure volume loop. How it is being measured? There's only one company in the globe that produces this particular product. Hemodynamics of all kind of equipment is best measured by pressure volume loop assessment. This is the gold standard one. Most of us don't have it. It's not available in India at present. The company is a ECA company, CD Laydowns. It comes with a pigtail with 12 electrodes. The pigtail can be inserted into the LV through aorta or transeptally into the ventricle if there's going to be a mechanical valve in the aortic position. So there is going to be change in conductance, current transmission between two electrodes. That depends on the distance between the electrodes, volume of the blood, because blood actually it's a partial conductor for current. So the number of electrodes that can enter into a LV depends on the size of longitudinal plaques, long length of the LV. In general, usually it's going to be 7 electrodes that is going to be entered into the LV. Rest of them will be inside the aorta. As the volume increases, there is going to be a counterclockwise movement, and you will get a trapezoid or rectangular shape like this, except for this one, which is a 8-shaped one. That means the particular electrode is going to the particular rectangle is going to have a part inside the LV and part outside the LV, that is inside the aortic valve. So how it is, after placing this pigtail, it's automatically done just like IABP machine. The curve is produced by the console automatically, and once you identify this curve, then once the machine identifies this curve, it summates the entire volume that has been brought inside the LV and the pressure that has been brought inside the LV, and produces a column like this, and average is taken to produce a typical pressure volume loop curve. So this is the pressure volume loop curve. This is the pressure volume loop curve based workload that is being done by the heart. So the volume of the width of the curve represents the stroke volume. From here to here, the stroke volume. The work done by the heart to produce that stroke volume is called a stroke work. In order to develop this much amount of stroke work, some amount of potential energy is utilized by the heart. So maximum amount of interaction between actin and myosin is going to happen at the end of systole, that is this point. So some amount of work is actually required even to release the bond that has been happened between actin and myosin. That is the potential energy that is being utilized here. So if this energy, if this red dot and going to be a pale blue dot is going to be bigger and bigger, the stroke volume might be bigger, but the MbO2, myocardial oxygen consumption, is going to be bigger. This concept needs to be understood. So stroke volume can be made higher, but there is no use of going to be a higher stroke volume if you are going to produce it at an increased MbO2. That means if you are going to have a increased potential energy, then it's not going to be useful. That point needs to be emphasized. So this can be a little confusing. So I remember only two lines: the green line and the broken blue line. The broken blue line connects between these end systolic, kind of aortic closure to the mitral valve closure. This determines the afterload. The green line is called as ES, elastance of the ventricle. This determines the force of contraction, kind of contractility of the particular heart. So if you give beta agonism, the green curve can become like a blue curve, and the potential energy cannot be increased, stroke work can be increased. Ultimately, it is good, more contraction is good for us. And if your curve, this broken curve is going to go towards this side, that means your afterload is going to be higher. That means the MbO2 is going to be ultimately going to be higher and higher. So this is the point which I would like to emphasize. Remember this red line. Whenever you see a pressure volume loop, look at in your mind, put a red line between that connects the end diastolic volume to the end systolic volume, end systolic pressure here. This is the afterload. So if your total peripheral resistance is going to increase, the red line is going to stand up like this. That means your afterload is going to be higher. If the contractility is going to increase, this blue line will make an angle which is called as elastance angle. This is going to stand straight. That is good for the cardiac output, but it happens at an extra stroke work by increasing both the stroke work and the potential energy stored that is required to maintain and relax the actin-myosin bonding. So this concept needs to be understood. So we need a optimal interaction between this afterload line and this contractility line or elastance line. This is a summary of this one. This is the normal curve. As the preload increases, Frank stalling mechanism, contraction increases. Your stroke volume, the curve, the width of this loop is bigger than this loop. The stroke volume increases, but the stroke volume happens at the cost of a stroke work and at the cost of some amount of potential energy. That needs to be emphasized. So as the afterload increases, the curve which was like this becomes like this because the afterload is increased. The aortic valve closes prematurely, and your stroke volume also decreases. That is the important concept to be remembered. And if you look at here, this is the red line is a normal line. You are giving a beta agonism. The elastance line, which was like this here in red, becomes like this. Your potential energy increases. The curve actually, the width of the curve increases. That is, the stroke volume increases, but at a cost of increased energy. MvO2 increases. So what happens with different mechanical support devices? This is your IABP. Once the IABP is placed on, the red one is without IABP, the blue one is with IABP. Definitely, end diastolic volume decreases. But since the end diastolic volume it's not a linear line, it's a non-linear line. That the effect that has happened on the end diastolic volume may not get reciprocated directly to the end diastolic pressure. So the difference is not seen much here. But look at the afterload. I told the line that connects between this point and this point is the afterload. I connect that line between this point and this point is the afterload. The afterload has dropped down significantly with IABP. So that is the primary reason why IABP helps. It decreases the afterload more than decreasing the LV-EDP. Ultimately, LV-EDP may decrease, but the first thing that is going to happen is decrease in afterload, and it leads to decrease in MvO2. So this is what we did in one of our patients. A kind of LAD PCA was done with IABP, high risk PCA with rotor ablation was done under IABP support. We thought there was a serious circumambulation without measuring the FFR. The FFR was significant. Since the patient was having IABP, we again equalized FFR under IABP and went inside and found this. So the FFR, which was initially 0.67, jumped to 0.75. So that means FFR definitely increases distal coronary perfusion pressure. The IABP definitely increases distal coronary perfusion pressure. Unfortunately, we all know it didn't translate into better clinical outcomes. We don't know the reason why. Let's talk about ECMO. The blue is the native curve of a particular patient with cardiogenic shock. LVEDP is increased, it's almost around 25. Isovolemic contraction phase, isovolemic contraction phase, blood gets ejected, and this is the stroke work done by the heart. As ECMO is going to be placed from 1.5 to 4.5, look at the afterload curve. As I told, the afterload curve is the curve that connects the mitral valve closure to the aortic valve closure. From here to here, the curve stands up like this. That means maximum amount of afterload happens when the ECMO is going to run at a speed of 4.5. And look at the width that is going to happen here. The width is shorter. So the amount of blood ejected by the heart is significantly dropped. Why? Afterload increases. So to conclude this ECMO related pressure volume loop, ECMO increases the afterload. It may increase the preload, leading to increase in LA pressure and PCWP. Because of afterload increase, it increases the MbO2. Stroke volume actually decreases. When you compare the width of this curve to the width of this curve, the pulmonary vascular resistance may also increase because of rise in PCWP. That is the principal reason why majority of patients who undergo ECMO can have a elevated MUO, though they can have increase in cardiac contraction initially. If it is going to persist, because if it is going to persist, then the aortic valve may the complete support of ECMO may prevent the aortic valve from opening, leading to significant afterload increase, and LV function may drop down. How to tackle it? It's suggested to either increase the contractility by giving some beta agonisms, or most importantly by decreasing peripheral resistance. How to decrease the systemic vascular resistance? Venting the left ventricle, that is putting a intra-atrial shunt, a tube kind of tandem heart, or an LV vent. These are all the things that can decrease the peripheral resistance. And if you look at here, by decreasing the total peripheral resistance, the afterload which was here was brought down to here with a better cardiac output, better stroke volume. So whenever these are all hemodynamic study, we don't know yet whether it is essential to put ECMO, essential to put an afterload reducing agent like IABP or Impella whenever ECMO is being placed. But these are all the hemodynamics things that has been shown in animal studies and some clinical researches. What actually happens with Impella? The initial trapezoid blue curve becomes a triangular one. This is a study this is the original curve from LVAD. LVAD has the same mechanism of Impella. It takes the blood from the LV and continuously ejects into the aorta. So your pressure trace will become kind of a non-pulsatile one. It's going, as the Impella is going to continuously function. The isovolemic relaxation phase and the isovolemic contraction phase, they have been taken out because, as I told earlier, the blood is getting completely kind of pumped into the aorta, irrespective of cardiac systole or diastole. And if you go from a 4.5 L VAD support to a 7.5 VAD support, the curve which was big like this here is dropped down here, and smaller. That means the stroke work done by the heart is significantly reduced. When stroke work done by the heart is significantly reduced because of decrease in afterload, the MbO2 is going to significantly reduce. These are all hemodynamic and theoretical kind of clinical research, bedside research. Not small bedside studies have shown, but long-term effective data is yet to be made available. So with this, I would like to show a couple of cases. Maybe I will go with this last case. This is left main case. This is a complex left main intervention. This is the guy, 88-year-old guy, a kind of critical left main 111 lesion. It was done with Impella support with rotablation. 1.75 burr was utilized for LAD and 1.5 was utilized for circumflex. Otherwise, routine PCI kind of ballooning and stenting was done, and we ended up doing a SKS stenting for this patient. Since he was 88, we didn't want to proceed with kind of crushing, like any types of crushing. It was done way back 5 years ago. So this, we started up like this, and we were able to create a decent result. Then we ended up with the result like that. So this is the second patient, non-STEMI, post-cabbage. This is a post-cabbage 10 years ago, diabetic, hypertensive, non-STEMI, severe LV dysfunction. It was done during COVID time. PCR was pending actually for this patient. So this is the right femoral artery. Look at this critical distal left main disease. CTO of RCA. This is the culprit lesion of the graft filling the OM. Graft filling RCA. Then there's a tight lemma disease. I mean, it was seen here. Yeah, you should be able to see here. The tight lemma disease in this particular position. Distal anastomosis lesion. Impella was placed in the right groin. A single axis Impella procedure was done. A 7 French sheath was placed through the Impella CP, which is actually a 14 French sheath. We ended up doing PCI with the support of guideliner to the SVG to OM, and again with the support of guideliner, PCI to lemma was done. Reasonable result was obtained, and the LV function, which was 25, actually went up to 40% on 1 month follow-up. He was doing fine later. This is the interesting case which was done 3 years ago, 4 years ago actually. 63-year-old male present to outside hospital elsewhere, high with cardiogenic shock, diagnosed to have a non-ST elevation MI, and then after stabilization, his creatinine was found to be 1.4, lactate of 7.6, drop positive. He was taken to cath lab. They did a cath. They found a kind of short segment occlusion here with the bridging collaterals. They attempted to open it. Unfortunately, they could not open it. Then the patient was transferred to our center. So with an IABP. So this was the cardiac cath of the particular patient with a cardiac index of 1.6 liter per minute body square. The echo was done at our center, which revealed a severe calcific aortic stenosis, the calcified rapid end of structure between non and right. There was no LV thrombus. LV function was around 15%, 10 to 15%. So he was shifted with an IABP. A patient hemodynamic support was initially escalated. The right femoral artery where the IABP sheath was there was escalated to an Impella CP. Cardiac surgery team found this patient to be at prohibitive risk for emergency surgical replacement. Hence, a TAVR was planned. Urgent CAT scan was done, which showed a severely calcified. The sheath is already there, is the Impella sheath. Severely calcified left femoral artery, which could not be used for TAVR. So, an percutaneous access of percutaneous left axillary subclavian, I mean, basically left axillary approach was utilized. So, right femoral artery was utilized for Impella. Before putting an Impella, we actually did a balloon aortic valvuloplasty. We tried to do a balloon aortic valvuloplasty, but it could not be negotiated. It was very, very stiff. So then we upgraded the IABP to Impella and proceed with BAV here with the Impella support. And then later on with the left subclavian axillary approach, S329 valve was deployed successfully. This was the end result. Thanks for Dr. Tharoon for sharing this case with me. Patient improved well and he got discharged after 7 days actually. Hence, these kind of complex cases require planning. Failing to plan is planning to fail. Thank you.
Excellent presentation, Dr. Nagendra. In fact, when you started, you said, I was surprised why you're presenting hemodynamics and pressure volume loop, but then you went on explaining the advantage of Impella over an ECMO and intra-aortic balloon pump. So, any comments, Dr. Amal?
First of all, I have to congratulate Boopathy talking on cardiac physiology on a Saturday evening at this time and keeping our attention right till the end. I think it was a good brush up to understand the difference between the various hemodynamic support that we have. I mean, yes, I think Impella is a fantastic device to have. I mean, my experience is just limited to one particular case here in Dubai. I mean, I don't know. I mean, even in Dubai, I would say that the prices, is extremely high. I mean, not many insurance cover the Impella, unless we justify the usage and, that it cannot be done without Impella. So just, Boopathy, how about the cost in India? I mean, approximately, how is it? And is this something that can be reused, that catheter, by any chance, or?
I don't think they have made the system in such a way that it cannot be reused. Small amount of clot is identified in that. I think that it will give a signal so that it cannot be reused. All these cases were not done in India. So it was done whenever a couple of cases were done for 6 years. In 2013, the last case was done in 4 years ago in 2014. But none of the cases were done by me in India. So I was a fellow there when we were helping those cases.
Yeah, because I mean, what about the other panelists? Any experience about the Impella in India and the cost, approximate cost? Anybody?
I
It
don't have, I have
costs,
not used it anyway.
no, Impella in India costs, there are two varieties.
Yeah.
So one is around 18 lakhs and other one is 22 lakhs.
2.5 Impella has two varieties that are available at present in India. So 2.5 is 18 lakh, CP is
Yeah, 2.5 is the one we use. Yeah.
by theory wise they give 2.5. Theory wise CP gives 4, but I've never seen CP giving 4. It goes to the maximum of 3.5. With the boost, it can go to 3.7 or so. CP goes through 13 French and sorry, 2.5 goes through 13 French. CP goes through 14 French. CP has got its own advantage of you can have a peelable sheath and you can put a 913 and a removable sheath. They come with a kind of post-close technique also with the newer CP version. These are all added advantage of CP. With CP, you can do a kind of single access procedure, while with the 2.5, you can't do a single access procedure.
Single access.
The sheath is the hub of 2.5. You cannot penetrate with the micro access or a cook needle.
Nagendra, can you explain that single access thing? I was not understanding. I don't know. Let's the audience also will know and let me also get educated.
So after putting Impella sheath, it's only CP through CP. The CP sheath has got a small hub valve. It is not recommended by Impella at all. It was initially done by Dr. Walmuth. It's called as Walmuth's technique. So what he did was he took a micro axis and perforated the valve either at 2 o'clock, 2 millimeter away from the boundary of the valve, or at 10 o'clock, again 2 millimeter away from the boundary of the valve. Having said that, it has to be done very cautiously because your Impella 9 French catheter is already inside the Impella system, Impella sheath. It has to be done very, very carefully. And once the micro axis is done, we used to go with micro axis, but people have done it with Cook also. Once micro axis is done, then again you upgrade your micro axis to a stiffer wire. Any wire is good enough actually. You can go with a supracore wire or ampere excessive wire, and then put a. We prefer at least a 30 centimeter long sheath. We actually put 45 centimeter if it is going to be complex case. So once the micro axis is done, upgrade it to 035 wire. Put your regular 7 French sheath, which is 45 centimeter long, and then do your procedure in the same sheath. Only thing is, while removing it, your sheath comes out first. If your sheath is not going to come out, the Impella motor will not come out. The Impella motor is 13 French. It will not come out. So your sheath comes out first. So what we did was, after pulling out the sheath, we used to, if it's in a protected PCI, we used to remove the Impella on the table itself. So we put a wire inside the Impella peel-away sheath. Let's presume I'm going to close the groin now. We close the groin, and if you want to, the advantage of having a second axis is on a different groin is you can go up and over. If there's going to be a problem, you can do a balloon tamper, and unfortunately, you can't do it here. So your access should be perfect. Your big bore access for the Impella should be perfect. There should not be any calcium. That there's no chance that you can take it's a 14 French. The 14, you have to add 16 French actually. The 14 French is the internal diameter, internal OD. You have to add another 2 millimeter for the external one. At least 2 French. Sorry, not 2 millimeter, 2 French. So if your access is perfect, single access is the best thing to have it. And then once you close it, let's presume your 035 is there in the large bore access at the end. You are closing it. Now once you close it, your wire alone is there. You can put the sheath of the micro axis, 4 French sheath of the micro axis, and take a shot to ensure that there is no leaks. If there is no leak, then you can take out the micro 4 French. It's just a 4 French. Take out the micro 4 French and then lock the per close. So just before locking your per close, you can put a 4 French sheath, hold the knot on your left hand, on your right hand you inject it, make sure there is no leak, and then you will remove the 4 French and then lock the sutures of per close.
I think Dr. Ashok Seth recently did the single access Impella supported a complex PCI for a couple of weeks back. He presented in a forum.
Okay, sir.
So I was also not understanding, so you made it very clear what is single access sheath.
Okay, sir. Thank you, sir.
So, okay. Thank you, sir. Let's now Dr. Selvamani will go ahead with his talk. Over to Dr. Selvamani.
Can you see my screen?
Yes. Yes.
Yeah. Thank you very much for the opportunity, and it's nice being with all friends and the August seniors around here, the twin Andhra meet here. And today I'll be talking on two important things which we have been practicing off late for some time. One is our lithotripsy and OPN balloon NC. And coming to this first case, what I'll do is I'll show you some cases, and then we'll go for the theoretical part of this topic. So look at this patient here. He's Mr. Subramaniam, and 65, came with non-ST elevation MI and significant angina. And look at the angio itself, it shows it's a significant calcium there. It's severe calcium. And this patient, I posted him for PTCA. So, as recommended, it is ideal to do imaging in most of the calcified lesions if it is available. And I did the imaging, I did a OCT here. And what it showed me is it gave me an idea about the vessel size, what is the reference diameter, and what is the length of the lesion, and what is the type of morphology why we have. So coming to calcium, usually you know that there is a calcium score which is basically based on OCT. And this shows the more the score, the possibility of underexpansion of stent is very high. And this is some trials which have shown that at what level, up to what extent of calcium you can go ahead and do only with balloon, or where you need extra newer devices. And most of the studies like Akasaka, they have shown that up to 500 microns, you can break it with a balloon. And many people say between 300 to 500, but it is not definite. But at least beyond 500, there is always a doubt. And coming to rota, and it is basically very useful for superficial calcium. If it is a deep calcium, rota has no role at all. And moreover, you need a wire bias in rota to really shave over the calcium. And the thickness of rota, what generally it is recommended in few trials is 700 to 800. If it is superficial, probably it is helpful. And after that, definitely you need other devices along with rota to crack here. So look at this patient here. Now, this was the finding here. It's almost, look at this 360-degree arc calcium in this patient. And the thickness of calcium is somewhere around 800 microns. And look at the length of the calcium. It's more than 30 millimeter. So it is a score is 4. Calcium score is 4, and it's a very severe calcified lesion. So what I did is, after this imaging has been done after 2 balloon, and after that I wanted to take a bigger balloons, like I wanted to take a cutting balloon or a scoring balloon so that I will dilate. But unfortunately, nothing could be tracked. The moment we take some bigger size device, it was not going at all. So when such things happen, like if you really cannot take a device, sometimes there are conditions where I couldn't put a OCT catheter or 2-size balloon also. So in such cases, we have no other alternative, we'll have to do a rota ablation. So I took a rota 1.5 bar to create a path. So mostly, many times, if you can track the devices, like whatever newer devices we have, that is excellent. But many times, it's so severe calcium, you still cannot track all these devices. So you'll have to make a path by using a rota there. It was 1.5 bar rota. And after rota, I could take this balloons there. So I dilated, and this was the finding in the OCT what I get. After rota, I could take this 3 NC balloon. See, rota clearly shows a fracture here. And this is a very clean shaven area. This is what the ablated area looks like, where rota has just touched and then cleared the calcium. It's the ablated area, where a clear shaven area, unlike here, where it is because of the balloon fracture there. And next what happened is I wanted to take a bigger balloon. I have done a 3 NC, and then I've done a rota, and after at this point I have achieved from MLA, which was less than 1 to 1.59. That is what we have achieved in the OCT. So when I put a bigger balloon here, 3.5, you see here, it is not yielding at all, significant dog boning in this patient, in spite of all these things. So next option what I have is I had got nothing. So I took a OPN balloon, which was 3.5 into 10, and went up to 35 atmosphere. And after doing this OPN, what happens you see here, so there is a significant fracture here, and then you see that the lumen has expanded from 1.59 to 4.1, which is an excellent thing. A brief introduction about OPNNC. OPNNC is a double-layered balloon, which is a unique technology. It increases the tensile strength and it gives uniform expansion. And it is a relatively low profile, but sometimes in significant calcium, very difficult to track. But it is relatively, for the size, it is a low profile balloon there. And it has two markers there, like any other balloon. And the main advantage of this is there is less than 10% growth even at high atmospheres of 40. And one advantage is it achieves linear compliance, like unlike any other NC balloon, where you cannot get this linear compliance at all. This is basically because of dual layer technology. And this controlled growth, what happens is it generally does not allow dog boning, which you saw with other balloons. And dog boning means the pressure is exerted unevenly and then balloon expands unevenly. Probably that can give rise to dissections and perforations, which is not seen with OPN. So this dog boning effect is not seen in OPN. That is a very big advantage. And the pressure effect is uniform at the calcium lesion. And the potential benefits of all this thing is probably you avoid significant dissection and perforations, but it can happen if you oversize the balloon. For example, what you should do is, if the vessel is 3, don't go beyond 3. If you are using it for post-dilatation, use it as 1:1. Or if you are using it to prepare the lesion, use one size lesser. For example, if it's a 3-size vessel, use a 2.5 balloon and go to very high pressures. Very high pressures does not cause perforation, but if you oversize the balloon, probably you can perforate. So this is the comparison with other balloons, where here working range itself is 25, can go up to 40, 45 here. Most of the other balloons, we know that RBP is somewhere around 18 or 16, depends on the company. And one advantage when you compare with Rota and other thing is it's a very less learning curve. Anybody who can take a balloon can use this balloon very easily. And remember, you avoid polymer sleeve wires like field FT Whisper when you are using OPNNC. Better to use extra support wires like Grand Slam. And as I already told you, when you are using it for post-stent or instant restenosis, use it as 1:1. And if it is for pre-dilatation, it is used lesser than one size lesser. And it is to be used with a specific inflation device where you have, you can take the atmospheres up to 55. Our usual inflation device does not have so much of pressure. Usually it stops at 30, but here it has up to 55. And beyond 20, you increase the pressure slowly. So these are some of the recommendations for OPNNC balloon. So look at this case. After OPNNC, what happened? Significant grade fracture seen in the OCT, and lumen from 1.59, now it has come to 4.14. Then of course, then I know the EL there. That's the advantage of having imaging there. I know what is the size of the vessel there. I should not exceed that size. So EL is almost 4.4. So I should not exceed the balloon size of more than 4.5. That is my limit there. So what I did is I deployed a 3.5 into 38 stent there. And initially we looking for the stent expansion. Distal stent had excellent expansion, but proximal was a little bit less. Then I took a 4.5 NC here and dilated and produced an excellent expansion, which is almost 100% or almost around more than 80% to the reference diameter in both distal and proximal segment of the stent. And with imaging, it's many times it's useful where you can use even 4.5 NC in an LAD, which otherwise I don't think anybody will do that. So this is the final result with the excellent position, and then no malapposition, no dissection, no complications, with excellent T3 flow. And coming to one more interesting case, what we do is, like, look at this case. This is a significant calcified vessel, and it's a severe calcium, long calcified lesion from here to here, and they're very longish. I think the length is more than 50 millimeter here, very long lesion. And again, it came with non-ST elevation, MI, chest pain. So I prepared this patient. Here I could take a little bit bigger NC balloon. I could track it easily. And after preparing with a balloon, you will concentrate on this OCT. See, this is the angio-co-registered OCT. And this white marker is the point where you are cutting this OCT. So just concentrate these images here. So at this point, there is significant calcium there. And when you come here, again, you see there is a very thick calcium, more than 830 microns. And then when you come a little bit above the diagonal there is something like a calcific nodule which is projecting, and the vessel is like this. And now again, these are some dissections because of the balloon dilatation, and macrophages and some cholesterol crystals are seen, and again thick calcium, and then small calcium fracture because of the balloon dilatation there. And this is what we had. So how this I wanted to use IVL, otherwise it was a very tough thing because I could track the device by any balloon there, so there is no need for rota here. And it's a very thick calcium, very deep calcium. I think this is a case where IVL will be very, very useful. So how we do IVL is, you do OCT, and now on the angio-co-registration, you mark the areas where there are thick calcium, where you need to concentrate, and especially something like a nodule where you might need to give more shocks. And you mark it on this, like on the OCT in the angio-co-registration, and you select those spots and you give the IVL therapy here. You know that IVL has a limitation, it gives only 80 shocks, and you can decide where you want to give more shocks with image guiding, and decide depending on the thickness of the calcium nodule, and you can spare some shocks also if you want to repeat it at some other point after you do the initial sitting if possible. But here it was a very long lesion, length more than 50. So I had to be very selective in giving this IVL shocks there. And after IVL shock, you see here what happens. There are significant fractures here. You can see the fractures. And many times I have seen when we do IVL also, even if you cannot see a calcium on OCT, but even if you cannot see a fracture on OCT, many times it produces microfracture and it alters the texture of the calcium. So it becomes softer, and you can expand this calcium very easily when you do IVL. That is the advantage of IVL. But here, when I did a OCT at the proximal LAD there, I was not satisfied about the expansion. So I thought I need to give one more shock there. So I gave some shocks in the proximal LAD again with the IVL. And then again dilated with bigger balloons. And this is the OCT after that. So it's a good expansion now. And there are areas of significant fractures here. You can see that. And lumen has expanded very well. And then it is a satisfactory sign that I can go ahead and stent it now. Whenever you are treating with severe calcium, don't take your stent prematurely unless the lumen expansion is at least 3.5 ml. Less than that, many times if you put, the stent may not expand. But luckily now at least we have IVL, you can use it for under-expanded stent also. But previously it was difficult. If the stent is not expanding, even after OPN, it was difficult. But now you can use IVL for under-expanded stent so that the stent expands. So here I have deployed this stent there, a long stent from proximal to mid. It's a single stent here. And then after stenting, you see that it's an excellent result with excellent expansion there. No areas of malapposition and no complications, no dissections, and well covered here. And you concentrate at this area where we saw the calcific nodule. It's very difficult to treat. Although it has not produced excellent expansion, but that area, it has an MLA which is more acceptable. The minimal stented area is acceptable. It is more than 5.4 here in this, and anything more than 4.5 in OCT should be an acceptable limit, and it's a good expansion, reasonable. Many times what happens when you try to expand this nodule, you take a bigger balloon, they expand, many times it perforates in the opposite direction. That point you should be careful. But luckily here there was calcium in this area also. That is why there was no problem, I think. But anyhow, if there is an acceptable thing, you should be careful, especially if there is a nodule. Directional atherectomy probably is a treatment of choice. I have used few cases, rota also. If there is a wire bias, rota also treats nodule. And this is the final, this is how that initiate to start with this case was severely long lesion calcium treated with IVL, image guided. And this is the final result which we produce. So nowadays, when we use IVL, we use imaging. We call it as OC-TRIPSy in our place, where you can localize the exact positions of the calcium and treat it accordingly with IVL. So the IVL was introduced in India this year in January in CHIP CTO conference, and almost 158 leading intervention cardiologists across India have used it. More than 375 coronary interventions, and it's definitely everybody is picking up and using it. And just a review, like lithotripsy for renal stones, which have been there for a long time, it is just a modification from that. And important thing is IVL treats both concentric as well as eccentric calcium. There are evidences that it treats both type of calcium there. This is from Disrupt 1, where concentric as well as eccentric calcifications has been treated well. And any complex lesions, like it's very, very useful, especially for the deep and thick calcium, where rota cannot do anything much, especially high-risk patients where you cannot do a rota. If you can take this IVL balloon inside, it's a really, you can treat most of the calcified lesions there, especially left main also, where it's a big lumen, rota may not touch, even 2 bar may not touch it. But here it can act on any vessel, left main, bifurcation, ostial. And of course, rotatripsy is another terminology where you cannot, when you cannot take this balloon inside, use rota, make a path for this balloon to go and then take it inside. And you can use multiple wire also. Like for example, you can use it buddy wires to take this balloon down, and then still you can use this thing. And again, Jonathan also says you use rota bar, create a path, and then take this balloon to dilate. And some important studies are Disrupt 1, Disrupt 2, and Disrupt 3. This is already published here, and these are all on the way now. And Disrupt 1, you clearly showed that in most of the patients, it is very strong initial performance and safety, low complications were the results of this. And this is what gave us confidence in using this lithotripsy in our day-to-day practice, especially severely calcified lesions. And it is a very minimally traumatizing and then optimized outcome. That is, it produces very good results, there is no doubt, and very simple procedure, unlike rota where you need a lot of experience and then operator dependent. Here, anybody who can just take a coronary balloon can do this procedure. It is so simple and safe there. And this is how that machine looks here. Here, this is what generates shocks here. And this is connected here. This is the button where you press. For 1 second, it delivers 1 shock. Each balloon has a capacity to give 80 shocks. You can select where to give how many shocks depending on the distribution of the calcium. Usually, there are 2 emitters inside the cell. The coronary IVL is a single size here. It is 12 millimeter balloon, and it emits each pulse at every second. And of course, you can use it any number of times. Sometimes in a very long lesion, you might need a second balloon also, but that's very rare. Thank you very much for listening, and thanks for the opportunity.
Excellent, Dr. Selvamani. Couple of questions from my side. Now, when you use the open NC balloon, initially when they launched, they said you have to use another stiff wire. So, but whatever I have used, I never use a stiff wire. I have used it on a regular wire, let it be BMW or Rinaldo. So what's your...
Yeah, sir, I had some experience. Actually, we have used a very high number of OPN in our centers. And what happens is, sometimes when you're using a polymer jacketed wires, like where it is coated wire, it can get stuck there. The balloon may not come out. It will get stuck in the vessel. So what happens is, you will have to pull both the wire and the balloon together outside. Only just balloon doesn't come out. That has happened. And that is why even the company recommends, it may not happen, but there's a high chance that the balloon gets stuck and you cannot remove the balloon. And only way will be you'll have to pull out even the wire and the balloon together. And again, you'll have to rewire with something else. To avoid that, generally it is recommended you use non-coated wires for OPN. And moreover, OPN is not very flexible like any other small balloon. It's definitely, there is some trackable issue, especially torch, significant calcium. So that is why they advise use extra support wires.
Thank you.
You can use it. You can use it in any wire, but it depends on the lesion if it's very difficult. But ideal guideline recommendation is this.
What is your experience, anything on this shockwave lithotripsy in a undilatable stand? So probably you thought the vessel is well prepared, and that scenario you have put a stand.
Sir,
we had some experience like this. Somebody put a stand and the stand is undeployed, and then we tried to use lithotripsy. Any experience like that?
Sir, this is very premature. Actually, we started using IVL, and after this corona, we have not used much of IVL. Till date, I have used only 3 cases of IVL, but all image guided. And post-stent for under expansion, still I have not used. You can, but there are some paper, I have listened to some European presenters where they have said for stent under expansion, only treatment is IVL. Because you cannot do rota, where some of our seniors said, but it doesn't work. And then even if you put OP and NC, many times it's so under expanded, severe thick calcium. After putting a stent, it does not expand. But only option is IVL, but I have not done so far.
Dr. Amal, any experience?
Yeah, I mean, we use a lot of OPN balloons, to be honest. I would say almost alternate cases we use OPN here. I think that is something, I think now it's become an essential tool to have in most cath labs. And we noticed after using that, our need for debulking devices has come down significantly. And in addition to that, we use a lot of orbital atherectomy here. It's another useful device, especially as you know, because of the orbital motion, it reaches the calcium much higher. And especially if the lumen is too big when the rotor floats, orbital atherectomy is a useful device. IVL I haven't used as yet, but as Dr. Selmani mentioned, I think its unique property is about ablating inside a stent. I mean, yes, you can use other devices inside a stent, but if there is a reason for under expansion is adventitial calcium, no device is going to help. So I think for restenosis, it's a very useful device. One thing I noticed with the OPN is, very valuable points Dr. Selmani mentioned about wires. And I noticed when you're doing bifurcation, I know, previously we all use 7 or 8 French, but nowadays with the profile of the balloons and things changing, I do a lot of bifurcation using 6 French. I think when you're using OPN, you need to make sure that you're not using a 6 French for bifurcations. I mean, 2 wires, I had more than one occasions when it get trapped with the OPN. So if you have 2 wires inside a catheter, you have to be careful. Once I had a wire, the first time ever I had a wire snapped actually was when I used OPN. So I think that is a word of caution I mentioned. If you have 2 wires, if you're doing a bifurcation, upfront go for a 7 French, especially if we're going to use an OPN. The other thing I noticed is, I think Dr. Selmani nicely highlighted the advantage of OCT or IVUS in calcium. I know there will be a lot of people, especially regular IVUS users, will still say that IVUS would be the preferred method for calcium. Clearly, you showed in your case, I mean, to identify the depth of calcium, it's almost impossible with the IVUS, especially if you're going to plan the appropriate debulking device like an IVL. I think if you for IVL, definitely OCT. I mean, it's nice you even coined this term, OCTripsy. I think if it's IVL, it has to be OCT. That is another important point that we mentioned. But both were fantastic cases. I mean, I was impressed with the IVL case and the final result you got. I don't think, you could have got that with the other devices. So, and I should say, I think rotablation is kind of slowly getting out of practice. I think I can imagine 1 or 2 years' time, there won't be any rotablators.
No, I think my opinion is these devices are a little bit bulky. Tracking those devices is difficult. There might be some percentage. Probably usage of rota will come down, but it may not go up because rota is needed to make a path so that you can take these devices inside. So many times, very critical, tight calcified lesions, you do rota, make a path there. But only thing is upsizing the burr and all those things will not be needed.
That's the advantage we noticed after switching over to orbital atherectomy. With a single burr, you can ablate any vessel size, and you don't have to upsize and downsize. So our usage will be probably an orbital atherectomy, then IVL, or orbital atherectomy and OPN in that combination.
Selvamani, one question just for audience. Like, for example, you have a calcified lesion in LAD, so you're not sure whether to use a rota or IVL directly. So how will you do it? Whether you will use some technique to understand that it doesn't need a rota and then go ahead with IVL directly?
Yeah, first, if possible, I would image it. So once you image it, you will get an idea whether it's a very superficial calcium or deep calcium. I have had cases where we thought it's a severely calcified lesion. We need to do rota and then but when you do imaging, you know that it is not a superficial calcium. The balloon or the catheter tracks easily. It's a deeper calcium, which many times you cannot make out on an angio. Even the outer calcium looks like a severe calcium in routine angiogram. So many times what I have done is I have deferred rota and deferred major other devices also after doing imaging. So, and many times if it's a very superficial lesion like which I showed you, when you cannot track a balloon, or when you see even the OCT catheter doesn't go easily, those cases you should start with rotablation. If you can track the devices, I don't think there's a need for rota. You can directly go with OPN or you can go with IVL, so which is more easier.
Yeah. So that's a very important message, I think, for all the audience. Like when you have a calcified lesion and you're not sure whether to do a rota plus IVL, so what you do is just pass any catheter and balloon, probably do a soft inflation, and there's no dog bone there. There's no need of a rota there. Go for IVL and complete the procedure.
That's right.
I think that's a nice message, Dr. Selvamani, and there's a nice tip for all the audience. So, any question from the audience? Can we know that, Ishan?
No, sir. No questions coming in here, sir.
Okay, sorry.
1 or 2 questions which were there, which you are there, where most of them, in fact, you have asked it, sir, intuitively. So I think it has answered most of them.
Okay.
Of repetitions only, sir. So that's it, sir. So you had it.
Thank you, Translimina, Selvamani. Nice meeting you here in these COVID times. Dr. Amal, just met you from Dubai. So nice introduction. Probably next time we come to Dubai, we'll meet there.
Sure.
And Dr. Nagendra, nice to know that you've done doing excellent work. And Dr. Subhash Chandra, thank you very much, sir. So thanks all, and we wish you all safe, another 6 months safe time, especially these COVID times. Thank you very much, Ishan.
Thank you
want to say?
In fact, sir, I wanted to conclude this, sir. First of all, thank you, sir, you for such nice coordination of this meeting. And I think we had an excellent elite group of speakers coming in this evening. And just to keep you informed that apart from being a Saturday evening, the number of footfall, I don't know whether it would be a right word to say footfall or the virtual fall was 400. Almost 400 plus, and I think on a Saturday evening, getting this number of audience, in spite of the fact that knowing that there are many other webinars are being conducted today evening, there are some very important one, and equally important was this. So thanks to all of you from joining overseas, Dr. Amal, from you joining here. It was a great pleasure to have you this evening from there. And it was not possible if it was not virtual, not all the time we can have everyone and getting this group together.
Thank you. Thank you,
sir, Dr. Nagendra Boopathy, sir, Subhash Chandra, sir. So nice of you, and Dr. Arkan, sir. So nice to have. And thanks to all the audience, their brilliant audience, the beautiful audience which made our evening